Today on Primary Care, I'm here at the Hartford Memorial Baptist Church in Detroit, and today I sat down with Sandra Taylor to talk about the opioid crisis in the Black community.
We need to have access to different treatment centers like there are in the white communities.
Hello, I'm Dr. Lonnie Joe, and welcome to Primary Care, the show dedicated to improving the health of African Americans. The current opioid epidemic is one of the largest drug epidemics in the U.S. history for all racial and ethnic groups. Attention to this crisis has focused primarily on white, suburban, and rural communities, with less attention being given to African American communities, which are experiencing dramatic increases in opioid deaths and misuse. If you're old enough, you may recall back in the 70s when opioids and crack cocaine were devastating Black communities. Our nation's response then was to declare a war on drugs. Today, the response is being framed as an urgent public health crisis. Substance use disorders and addiction are now viewed as a disease that can be prevented and treated. Why switch? And why the rise in opioid deaths in the Black community? My guest today is Sandra Taylor. Sandra joins me to talk about this urgent issue. Mrs. Taylor is a director of pharmacy services at a major hospital in this area and has been on the front lines of the opioid epidemic, holding several leadership positions in pharmacy operations, and currently serves on the Michigan State Board of Pharmacy. Ms. Taylor, welcome to the show.
Thank you.
Sandra, here's an interesting slide we're going to put up. This slide shows CDC statistics from 2019 and 2020, where it shows higher African American rates for overdoses than the rest of the population, including all racial and ethnic groups. You wouldn't notice from what we hear. We don't talk about this enough to have this common knowledge in the healthcare community and the lay community. What should we do to correct this? How do we keep this ball up in the air and in the public eye?
Yeah, and that's an excellent question. Right now, the problem is the illicit drugs that are out there in the Black community. When we're talking about the illicit drugs, we're talking about like the fentanyl that's out there. And no one realizes that right now, prescribed drugs, they're not prescribing opioids for African Americans because there's so many myths that African Americans don't respond to opioids, prescribed opioids. So, as an alternative for that, they have no alternatives or no way to support their pain. So they're using the drugs that are out there, and they're using the illicit drugs. And so, and those are, and I'm sure we'll talk about that later, but they are much stronger and much potent than they have been in years past.
And probably not necessarily available from an information standpoint of view to people in the street to actually understand what they're getting and what the potency is, what it looks like. You know, when in times past, you could identify these things much better than you can now. Now it has a different look, it has a different face. And somebody else tells you, yeah, it's good and it'll take care of your pain, and you're not sure what you're getting.
That's another really good point. Right now, what's out there now, the illicit drugs that are out there are like 50 times to 100 times more potent, like your standard morphine.
50 to 100.
50 to 100 times more potent. And what they're doing now, they're lacing, like, you know, fentanyl, they're lacing heroin, and they're lacing these other drugs with these illicit drugs, so they never know how potent they are. And so that's what's leading to the deaths, the lack of education and information that's out there for the Blacks, for African Americans.
Let's talk about the historical perspective of this. There have been three phases basically that's been identified in terms of this overdose or wave of overdoses that we've experienced. With the first phase basically starting in the 90s, where the opioid deaths basically came from prescription drugs.
Yeah, yeah. And that's in the 90s, there was a big push, a big drive, and it was everywhere, that to make sure that your patients are not suffering. They shouldn't be in pain and suffering. So it was nationally, there was a big push to prescribe, prescribe, prescribe. And those drugs that were being prescribed were opioids. And I think at the time, it wasn't considered how addictive these drugs are. And so what happened is once you prescribe them and the prescriptions you're done with your prescription, and now you're addicted. And now what's the alternative? And the alternative now is to get the illicit drugs.
So we go from a phase one, so to speak, to a phase two, which basically was the uptick in heroin usage.
There you go. So now we're out and we're trying to get our drugs. I don't want to say so much, but out on the streets now because you're no longer being prescribed. And so now you have those addictions and all of the side effects, the withdrawals and all those sorts of things.
And stress on the healthcare system.
Oh, most definitely, most definitely.
Emergency room utilization, inpatient admissions. It just snowballs from there.
Snowballs.
But then we hit the third phase around 2012, 2013, where the synthetics really begin to come on the scene.
Oh, yes,
and you're shaking your head because that's a bad character.
Yeah, when I read about and I hear about synthetics, it sickens me. Because years ago, and we're from the same generation. You didn't always have to overdose. You didn't always have to die. You almost sometimes had a second chance.
As a matter of fact, a death, depending on how far back you go, death from overdose was fairly rare.
Absolutely, but because these new illicit drugs are so potent, you don't have that second chance. So it's really it's scary because everyone knows someone or someone's family member or friend that has been impacted by this, and you want to think that they have a chance. But with these new drugs out there, some are saying that it's almost a fourth wave coming. Because the way these now the heroin and those other drugs are being laced with fentanyl, which is so potent.
So back to the initial slide that we showed, the percentage of African American deaths per 100,000 leads the way. Are we seeing any real reasons for that we could put our finger on and point to?
The reason why it's leading the way is because now we're more aware of prescribing for opioids. Everyone's aware. So whites now, where they were getting their prescriptions from their primary care physicians or their physicians, are no longer doing that because even our physicians now, our practitioners, are more aware. And now the government has also gotten involved. And so they have restrictions and things like that, so that they're being monitored. But now, remember, African Americans were really not part of that because there was always a myth that African Americans, there are a couple of things. African Americans were known not to respond to, their pain level was different, that we could tolerate pain a little bit better, that our blood clotted differently, and that our skin was much thicker. So physicians wouldn't prescribe those drugs for us. So we were always out getting our drugs if we had an addiction out on the streets, if you will, or our alternative were the illicit drugs. So now you take away the prescribed drugs, you lower that with all the things that are out here now, all the systems and processes and support that's involved, and now guess what? Now here we are, we're still out there, so now you see it more in the African American community.
That's amazing that you should point that out. It brings back memories of seeing it myself in emergency rooms and stories that we hear about emergency rooms years ago where if you were an African American and you had pain and you were in the emergency room, it was 30 questions before you were treated and still probably undertreated or underdosed, depending on where you were in that setting. We've got a long way to go to educate not just the lay public, but the prescribing physician population and the healthcare systems who basically play a role in this also in terms of the rules and regulations that they create, and of course our government in terms of what we are doing from a standpoint of view of saying this is the way it should have happened, and it's usually after the fact and lawsuits are involved. But here again, I think there's a role for everybody to play throughout our society in terms of trying to help this particular problem that we have. What are we doing in terms of addressing this in particularly this fentanyl crisis? Because that is very scary. I mean, you just mentioned 50 to 100 times, more potency. That is very scary in terms of what people can actually get their hands on in the street.
Absolutely. Another good question. And so we need to have access to different treatment centers, like there are in the white communities. There are treatment centers, and there was just recently there's methadone that you can use, and there's also buprenorphine also. But in our community, for methadone, you have to be part of a clinic, which is a federally run clinic. You're there every day to get your dose. There's no privacy. But in the community, buprenorphine, you can get a prescription. If you're seeing your physician every day, you can get a prescription for buprenorphine. As a matter of fact, there's a new act that was just passed. It's called the MAT Act of 2022. And so what that means, before buprenorphine, physicians had to get a waiver from the federal government to say, yeah, I can prescribe this. But then they were all under a lot of scrutiny. So a lot of doctors didn't feel very comfortable getting that waiver to write for buprenorphine. But now with the MAT Act, they don't need a waiver.
The stigmata associated with this is real. I've seen this for 30 years in terms of how we have not been able to actually address these issues, and to a great degree because of the stigmata that's associated with it. If your doctor is providing the prescription for you, that's a totally different world as opposed to you going to the clinic, okay? No matter who's running the clinic, whether it's private or run by the hospital, I mean, it doesn't matter. Over time, that association sticks out and nobody wants to. I've had situations where people would say, these kinds of patients can't come to the office on this day. They only can come on this day at these times so that they don't mix with the regular patients that we're treating for other disease states. That kind of stigmata still exists.
Yes, there is. It's for African Americans, they feel criminalized because way back, as we talk about the different phases, they were considered, if you were taking drugs and it was found and it was made relevant
Mm-hmm.
to the system, you were considered a criminal and you were incarcerated.
Yeah.
And so that's why, and so African Americans are so afraid. There's so much fear because they feel that they're going to jail. There's stats to show that there's a high percentage, greater than whites, that are right now, just because of misuse of opioids. Just by using it, they're now incarcerated for long periods of time. So it's their stigma. And then you're right. You're a criminal. They don't want you to come to their offices and those sorts of things. So you're absolutely correct.
We used to have several locations around this community for treatment for patients with addictions of various sorts. Now people have to hunt and hard to get into programs. I mean, what are we doing in terms of providing more services in this area? Because really it becomes a community-wide responsibility.
Right. I think what we want as African Americans, and even as we hear this, from patients, I want someone that looks like me, that trust. They want to see an African American. They want to talk to an African American. They don't trust the system, if you will. And so I think what we need to do, and you don't have to be a healthcare worker. I think we all need to get out in the community and make them feel more comfortable. We need to educate ourselves so that we can help those who are in need. And that goes into, churches and those
Mhm,
sorts of things.
mhm. So all of a sudden, a few years ago, we get this explosion of attention on this issue, and it seemed to be directly connected with rural whites overdose in that community. 60 Minutes, New York Times, Wall Street Journal. All of a sudden, that seems to lead the way in terms of us changing directions, and instead of this being an illegal inner city African American issue, now it becomes a disease and deserves treatment. We'll take it, okay? Why? Because we still need to address these issues. Is the federal government behind this to the degree, as you see it in your vast experience? Are they putting the dollars in the right place so that we can actually address these issues on a community level?
I think they are, but I don't think it's fast enough. That's the problem. I think that the rate of addiction is moving so quickly with these new illicit drugs. Like we said, there's going to be now a fourth phase with this fentanyl and all the, and all the lacing. So I think they are, but it's not fast enough. I've read where there's grants out there. They're helping different programs in the community, but it's not fast enough, and it's not in a way that African Americans want to hear it. We have to speak their language.
So from a scientific standpoint of view, what exactly are these drugs doing to the body? How does the addiction process actually take place?
That's a good question. So right now, what they do is they activate the receptors in the brain and in the spinal cord and other areas, and so you get this. It helps with your pain, but also it gives you this euphoria, and that's what's so addicting. They want to come back because they want that euphoria again, that pleasure that it gives you. And at that point, I recently read something that said within 3 days, you can be dependent and addicted within 3 days of that use. So to me, that's pretty scary. That's pretty scary, especially if you're being prescribed opioids. So that's pretty scary.
So a lot of this could start with that inpatient admission prior to discharge in a hospital setting where we use narcotics on a more liberal basis.
So that goes back to that new MAT Act, where it's where they can prescribe these medications: buprenorphine, methadone, and naltrexone. Now that we can, because the MAT Act, remember, says that you as a physician, you don't no longer have to have that waiver. So if you get a patient that comes in that needs treatment, you can treat. You can treat right then and there. However, African Americans are not normally coming to their physician's office because in the communities, low income communities, there's no physician offices in the communities like there are in the white communities. And so they don't have that access. They're not
Exactly.
coming to the hospitals, they're coming to the emergency room.
Mhm.
But then again, you have that stigma that you have to be concerned with.
Do patients have to sign a contract to participate in this kind of care or treatment from a particular doctor? Because without some control at that level, patients will doctor shop.
Right, and that's a good question. With this, from what I understand, with this new MAD Act, that a lot of those requirements have been removed, and so they're trying to make it easier for patients. But again, it's not in our community, in the Black communities, low-income communities, and that's where you see most of your addiction and the misuse.
Right.
Right.
And if the answer is addressing this underprescribing, which seems to be a big part of the problem, that forces people to seek help or services from the street side, we need to be addressing that and take the stigmata away as much as possible. Some of the restrictions, like you say, under the MAT Act, is being removed. But we don't hear that. This is not a public discussion necessarily. It's kind of a hidden, behind the scenes. Okay, I mean, everybody has disasters of these sorts in their family. I don't know a whole lot of people who don't know the downside of social being in this country. You got a cousin, you got an uncle. There's somebody in your family who suffered from. Everybody's got somebody they know has been in jail, that sort of thing. Okay, why aren't we not talking about this? Because that's going to be a big part of the solution in terms of getting the care and the services to the
And
population that needs it.
yeah, and I agree with that. I think, even on that professional level, I think there's opportunity for the government to make it a requirement, that we take courses in implicit bias. It
Hmm.
needs to be that. And then I think, where do we go where where we can trust, where African Americans can trust? Where do we go? And so, one, we're not going to come out of our community. We're going to stay right there in our
Exactly.
community, right?
Healthcare is local.
Healthcare, and we know back way when we look in slavery, where did we always go?
Hmm.
We went to church.
Hmm.
And so we've always relied on church, religion, those sorts of things. So I think that's a huge opportunity to get our churches involved, because where they're going, they want trust. They want to know who can I trust and who speaks my language. And we can't educate them according to what we're reading at a different level. It has to be at their level so that they understand it. So it's going to take all of us.
Right. And well, I can talk about a whole lot of societal ills that need to land on the doorstep of the church, where the church needs to take the leadership role. Trust is probably the most important factor. If you don't trust me, you're probably not going to follow my directions or instructions, or take the pill or not take it at all. Don't take it properly. Try somebody else. Everybody's got a pill book and got information for everybody else, and people will experiment. But the church seems to provide more stability when it comes to some of the tougher issues. I noticed that if we look at what happens in the prison system, the church influence there is huge now in terms
Mhm,
of
mhm,
changing the lives of people that are there,
mhm.
whether it's Christian or Muslim. But it's huge, and here again, some of that can be transferred on the outpatient side and put it in an arena where people are more trustful. We cannot run from that responsibility, no matter who we are. And I think you're right.
Absolutely.
A lot of that needs to be part of the mission
Mhm.
of the church. 25th chapter of Matthew. That's where it is. Part of the mission of the church. Okay, good. So what's coming down the pike? I mean, we're always looking for like you said, the bad side is that there may be a phase 4 in terms of this
Oh
opioid
yeah,
addiction. But
yeah.
are we looking at any new drugs or any new approaches
Right.
that we could count on?
Yes. So something just came out within the last couple of weeks, and I just saw it in the New York Times, where the government is looking at Narcan.
Hmm.
And Narcan is, if you will, is kind of like the rescue drug
Hmm.
to prevent overdose. It blocks those receptors.
Hmm.
And so now there's conversation. Um, I think it's at an early phase where it will be over the counter. And that would be great, because if you have a family members who's suffering, who you're concerned about, or a good friend or a loved one, you can purchase Narcan over the counter, no prescription, no nothing, anywhere. across the states and have that available to prevent that overdose. So that's significant.
I noticed that there's some real talk and discussion about the availability of Narcan on college campuses, in the workplace now.
Oh, yeah.
The physicians in my group, we all have a dose sitting right on the desk.
Oh, yeah.
And we're always checking to see if it's expired because we need to renew it.
Right.
Just in case you need, the life that you save is right around the corner in these kinds of instances. So we have to be prepared.
So just imagine being able to walk into a retail pharmacy and just pick it up off the shelf.
Exactly.
And that's what we need.
Exactly. If we can have ADE devices and teach people CPR across this country like we have, we can certainly institute something like Narcan as part of what we do to help a crisis like this. That's very important. Thank you for bringing that out. We're out of time, and we could go on and on because the questions don't stop on this issue, because I just don't think that the progress is there yet. We have not told this story properly.
We have
at
not.
any level. I mean, whether it's at the administrative level of services units that are provided, like hospitals. I remember when every hospital in this community almost years ago attempted to have drug clinics and detox clinics and that.
Yeah.
And now they're hard to find. It's almost gotten to the point where people say we don't want to have that kind of element in the type of services
and with
we provide.
buprenorphine being available and physicians not having to get that waiver, why not have in the Black community where they could see their primary care physician and be prescribed buprenorphine? Why should they have to go to a methadone clinic?
Right. We're prescribing drugs for hearts and lungs and kidneys
Exactly.
and everything else. This needs to be in the regimen of what we do.
Yeah, and buprenorphine has less side effects than the methadone, even though there's benefits of methadone.
Right.
Don't get me wrong, there's benefits of all three drugs, but in the white community, they're utilizing buprenorphine, and that stigma, they're not being seen walking into methadone clinics.
Sandra, this has been outstanding. Thank you so much for coming and on such a very important topic and helping us and the community understand this better. We really appreciate you. We're going to do this again, okay?
Thank you.
Our guest has been Sandra Taylor, Director of Pharmacy Services at one of Michigan's prominent healthcare systems. Reducing opioid deaths and misuse in the Black community will require culturally relevant prevention and treatment efforts designed to restore and maintain optimal health. For Primary Care, I'm Dr. Lonnie Joe.